So after you've done your range of motion testing, right, you'll take the person, why don't you go ahead and lay down actually. Yeah, so that you're flat. Okay, so that if we can, just check in with his flexion, his overpressure, bringing him down into some extension, making sure he has full extension. You've done all your special tests. I like to make sure I kind of palpate through all of the musculature, okay? VMO, VL, usually is going to be pretty riddled with some trigger points. Up here in rectus femoris, you're going to feel some trigger points that are there, and that'll be helpful to know in your exam. So there's your palpation. If you'll bend your knee on this side, yeah. So you'll feel the inferior pull, you'll give it a little push. Here's his patellar tendon, give it a little push. Medial and lateral joint lines, give them a little push, making sure that we don't have a lot of that tenderness, that where we might think the meniscus is torn. And then, good. So then from there, I'll take and just make sure that we've got some patellar mobility, okay? Going from medial to lateral. It should move about halfway out of beyond the plane here, or a third to halfway out of the, if I'm going medially, it's going to pass that medial point here, and so we should see it kind of poking out on the other side, and then vice versa, we should be able to push it all the way, and it's kind of poking out at me on this side. So I should be able to move it pretty freely when it's an extension. And then if that's in your way and you're like, wait, why isn't it moving so much? Get them totally into extension, right? Because then you've cleared out the groove, and now we really have the patella able to move very, very freely. Okay, we've got inferior and superior. If you feel a restriction like you potentially would post-operatively with an athlete, you're going to do this and turn it into your mobilization. So you're going to just come here and you're going to hold inferiorly if I want to get in line with his thigh here, and I'm going to give it a little inferior glide. Okay, you'll hold that however you guys are taught to, 30 seconds, 45 seconds, give a little oscillation into there. If you needed to go superiorly, usually we'll see either that extension lag or flexion where we get stuck in. And then we've got our medial and lateral. And if it is restricted into medial lateral, you'll go thumb over thumb or thumb next to thumb, whichever you prefer, and you'll create the joint mobilization that way. Does that make sense? This is like the easiest possible thing that you could do to the knee. All right, that's if that's a problem. Remember, if this is patellofemoral pain, they're going to have loads of patellar mobility because it's not the knee's fault. It's somebody else's fault. You got me? So then if I know I'm dealing with not a knee injury, it's not post-op, I'm not seeing a mechanism for meniscal tearing or ACL or anything like that, I am going to evaluate your hip mobility, which we will do in our next session, and you'll make sure and really rule out lumbar spine and hip, because this guy's usually to blame for this guy here. Okay? So then we've got the next thing coming up. You guys know all this already from musculoskeletal, is you probably were taught to stabilize at the femur, come and hold just distal to the knee, and we're going to be in your tibia. You're going to load directly over, and you're going to create a posterior tibial glide. Okay? If I flip him over and we push anteriorly, we're going to create our anterior tibial glide, right? Or if I stabilize my hand on the tibia and I push through the femur, I've done just that, right? You can flip it. Okay, what I'm suggesting that we try, so here's the anterior glide, right? When you go into, go to your belly a sec. When you go to the anterior glide, the only thing you have to be concerned with is that he's got some support right here with his foot. So you want to make sure you stack some pillows or a wedge or something, so that way you have free access to the tibia. If you keep him all the way down here like this, this just doesn't put you at the right angle to create the mobility that you need. Does that make sense? Okay, so then let's flip you back over. All right, so now posterior glide, we did that. Okay, this is what I'm suggesting. So, you see that blue wedge in there? That's the wedge I refer to, okay? There's a little mobilization wedge. But what we're talking about here is if you know, here's my tibia, and I'm on the medial condyle of that tibia, okay? And I can either stabilize here or stabilize here on the opposite side of the tibia and the fibula. If I've blocked him on this side and I glide him into this medial glide, which is a posterior glide of the medial condyle, okay, that's going to create some rotation for me. Does that make sense? And it's going to create a, which direction rotation? A medial rotation, okay? If I stabilize my hand medially and anterior or posterior glide him on the lateral condyle, I'm creating what kind of rotation? An external rotation. Are we all okay with that? If I take and stabilize the lateral and really use my fingers like a lumbrical grip on the back side of his leg, and I take the tibia and I pull it towards me, that's an anterior glide, right? That goes with a posterior glide on the lateral, which creates external rotation. So if I need extension, that's a way to get it, going through external rotation, because you know they go together. Does that make sense? Now you could take up some slack wherever he feels he's got good motion, and I just kind of sit on that foot to stabilize it, and I can do it like this. Does that make sense? So I'm creating rotation. Versus this way, if I'm creating medial rotation, I'm going to push posteriorly on the medial, and I'm going to glide anterior to me, or sort of pull into me, creating anterior glide on the lateral condyle. Got it? So it's just elevating your manual therapy just a little bit to be a little more specific for the clients who are getting stuck with that end range flexion extension because you haven't given them back tibial rotation. Okay? Got it? So that's kind of some stuff that you guys can be practicing for the final practical.